Thank you. The next item of business is a debate on motion 23342 in the name of Lewis MacDonald on supply and demand for medicines. Can I invite those members who wish to speak in the debate to press the request to speak buttons now, and I call on Lewis MacDonald to speak on behalf of the Health and Sport Committee. Convener, please.
Thank you very much, Presiding Officer. I'm delighted to open this debate on behalf of the Health and Sport Committee on the report of our inquiry into the supply and demand for medicines. I would like to start by thanking all those who gave evidence to our committee in person or in writing, and the committee clerks, spice researchers and other Parliament staff who assisted. We could not have made this report without all of those. All our recommendations were agreed unanimously by all members from all parties, and I am sure members will also all agree that I should extend our thanks to all those working in health and care who have done so much to keep so many people from harm in recent months. This report is focused on what needs to change to give those dedicated staff the best chance of success in the future. But the Health and Sport Committee has never lost sight of the vital work being done every day in the care sector and in the NHS. Our core job as a parliamentary committee is to support those who work in our public services and those who use them by seeking ways to strengthen those services, both by improving the service itself and its delivery to the public, and by delivering it more effectively and more efficiently. That scrutiny is right at the heart of our parliamentary democracy. The well-earned respect for our health and care workers must not be used as a barrier to scrutiny and constructive criticism of health and care systems as a whole. Our job is to ask difficult and searching questions and to draw conclusions from the answers which will help to make a difference. The government's job is to respond to those conclusions, and in this case, extracting a full response from ministers to this substantial report has proved to be a challenge in itself. I think it is important to put on record that the government's full response to the recommendations of our report, published back in June, was received by the committee clerks and by members only yesterday afternoon. The proper working of Parliament's committee system requires the full engagement of government ministers with the work we do, and it is a fundamental requirement of democratic government to be fully accountable to Parliament at all times. Ministers did reply to our recommendations before our debate today, but it is disappointing that it took them until the last possible day to do so. This is, of course, a large and substantial report covering a range of complex topics: drugs budgets, prescribing practice, the dispensing and consumption of medicines. Each of these 4 areas could easily have justified a major report in its own right. We took the view, however, that they were so interrelated that change in one area would inevitably lead to changes in the others. We wanted to shine a light on the reasons for the continuing rise in the cost of medicines to the NHS, now standing at over £1.8 billion a year. Our attention was soon drawn to a report by KPMG, which showed that up to half of all medicines prescribed and dispensed were not actually consumed as directed. This is clearly an enormous and an annually recurring issue, yet we could find little evidence of anyone taking any concerted action to address it. Altogether, we made 129 recommendations on how medicines management in Scotland could be improved, from straightforward adjustments to more fundamental changes in how the system performs. Much of the process of approving new medicines is done at a UK level, so we looked at those reserved areas too. Scottish ministers or their representatives have a seat at the table in every area we examined. The decisions they take, the input they make and the influence they wield do make a difference and have real-life consequences here in Scotland, and they are therefore accountable for those actions to this Parliament. It is one of the great strengths of parliamentary committees that we are free to follow the evidence wherever it takes us, and I would encourage ministers to welcome our scrutiny on that basis. The most important conclusion of our report is that the system of supply and demand for medicines in Scotland does not have a focus on patients. It is therefore disappointing that at no point in the very substantial response from the Scottish Government is this conclusion addressed. And perhaps the Minister will be able to indicate in his contribution whether he agrees with the committee on this central point. Throughout our inquiry, we were presented with issues which pointed to that conclusion. And many of those issues appear to go beyond medicines to point to wider-ranging problems within the NHS. The most prominent of these are the way that information about the patient experience is collected and the infrastructure which is used to store, share and analyse this information. Lack of information on the outcomes of prescribed medicines is of huge concern. The impact of taking medicines on individual patients is not being examined, and even worse, it is not being routinely sought. Patients in primary care are not receiving follow-up care to ensure that medicines prescribed were effective, or even to find out if they were taken at all. We find the lack of effort to understand people's experience of taking medicines impacted the system at every stage. Evidence described the improvements that could be gained from the collection of outcomes data during research and development through to consumption by the patient. As we state at the beginning of our report, we are clear that gathering, analysing and sharing this information in a comprehensive and systematic way across Scotland would be the single most beneficial action to result from this inquiry. And we urge the Scottish Government to highlight how it will take this forward. A lack of suitable data and IT has the potential to cause harm to patients. Systems designed to transition between primary and secondary care are not sophisticated enough, and the then Chief Pharmaceutical Officer told us this crossing of boundaries between care settings was where most harm happened. We welcome work being done in this, but we are concerned about what is happening for patients in the meantime. We find, for example, that patients ready from discharge from hospital could face hours of delay, sometimes resulting in an additional night in hospital because of delay in preparing their medicines. When we challenged the lack of action on this, we were given a whole list of reasons to explain why a doctor's prescription in hospital takes so many hours to fulfil. This glaring example of a lack of patient focus seems to be beyond the ability of NHS leaders at this point in time to resolve. We have recommended that relevant medical records be available to all health professionals who need them, and we have again emphasised that it is patients who should own this data. We note the speed with which record sharing has been put in place, quite rightly, to meet the challenges of the COVID-19 pandemic. We want to see equally swift and decisive action to make records fully available to all professionals at all times. We considered, for example, the implementation of the Hospital Electronic Prescribing and Medicines Administration, or HEPMA system. Its commendable core purpose is to generate data and outcomes. The business case was agreed back in 2016, but not a single board is yet in a position to gather that data. Many are still in procurement, and many are using different softwares. The few systems which are in use are not being fully utilised to analyse information on outcomes. The Cabinet Secretary wrote to us earlier this month and said that good progress is being made in implementing HEPMA, stating that the implementation date across the country is not in fact March of next year. So perhaps the Minister could clarify when he expects all boards to have functioning systems delivering information and when they will all be using this tool to full effect. HEPMA is a perfect example of one of the other key concerns that arose throughout this inquiry, a lack of effective leadership in the NHS. Evidence presented to us by senior health leaders detailed issues and problems throughout the system, but rarely explained how these problems would be addressed. We heard repeated acknowledgements that systems and governance were not in place governing the various aspects of a medicine's journey from research to patient, but we also observed a lack of willingness to take responsibility to deliver change. We heard, for example, that reviews of prescriptions are not taking place as a matter of course, which contributes to potential harm to patients and to waste. One director of pharmacy told us a medicine that is prescribed but which goes to waste is, in effect, the most expensive medicine we could buy. We also heard evidence that a lack of knowledge about non-medicine options was leading to a continuing failure to maximise the potential of social prescribing. In this year's budget inquiry, for example, we found that just over £19.5 million out of £8.5 billion allocated to integrated joint boards will be spent on social prescribing, less than 1%. Our report in February recommended that figure should be at least 5%, and the Government accepted that recommendation. We found a gap between the expectations of the Scottish Government and what happens in reality in GP surgeries in a number of areas: the review of prescriptions, social prescribing and realistic medicine, to name but three. This caused us to wonder how the policy objectives set by Government are being communicated and measured and evaluated. The obvious vehicle for requiring behaviour change is, in the view of the committee, the General Medical Services contract. The contract does not, however, appear to require adherence to these policies. Evaluation of the contract seems to be a long-term project. It will be 3 years before monitoring and evaluation priorities are even determined, and indeed not all the changes made to the contract in 2018 will be subject to monitoring and evaluation. We are also concerned at the lack of evaluation of the role of GPs in our primary care system, the freedom they have to decide whether or not to adhere to national policy. As recipients of almost £1 billion of public funding, levels of accountability of GPs are surprisingly low. The report recommends consideration of how the contract can be amended to require better systems, for example, for prescription reviews. Similarly, the committee believes the community pharmacy contract could do more to require pharmacists to undertake monitoring and evaluation to maximise the work they do in communicating with patients on their medicines. Many excellent opportunities for data to be collected on the patient experience are not being taken simply because it is not mandated by the contract. Now, I won't speak for the Minister, he will speak for himself, but the Government's response to many of our challenges does appear defensive. But I hope that on reflection, Ministers will agree with our central proposition. If patients are truly put at the heart of the system for the supply and consumption of medicine, we will get a more efficient system and deliver a better service to patients. And on that basis, I move the motion in my name on behalf of the Health and Sport Committee.
Thank you very much, Mr MacDonald. Now call Joe Fitzpatrick to respond to the Government. Minister.
Thank you, Presiding Officer. And I think I want to start by agreeing with the convener about that central premise of that patient-centredness. I think that's important. I want to start my contributions, though, by putting the report that we're discussing into context. With regards to the timing, it's important to note that the evidence sessions on which the report is based concluded at the start of the COVID-19 pandemic. And I'd like to take this opportunity to acknowledge the remarkable job in moving quickly and effectively to manage the threat posed by the COVID-19 pandemic that our health and social care system have done and continue to do. A point which I think was agreed by the convener. Since the evidence session closed, working practices across our health and social care system have adapted rapidly to minimise the threat to life. It is these very serious and indeed these very systems, and indeed under the same leadership criticised in the report by the committee, that have ensured that medicines continue to be provided to patients safely and effectively in unprecedented times. In the face of heightened global demand for medicines as a consequence of COVID-19 pandemic, Scotland's NHS did not run out of medicines and managed the tremendously difficult job of balancing supply and demand to ensure this. And I would echo the disappointment expressed by the Health Secretary in her response that this report risks damaging the people of Scotland's trust in the NHS and the care that it provides. And I know that was not the committee's intention, and I hear in the convener's opening remarks where I think he made that clear also. But it is the view of the Government that this report goes far beyond the published remit. Some of the evidence presented at the hearings has been misunderstood or presented inaccurately. Some of the highlighted areas are reserved to the UK Government, and much as we would like to act on these, we simply do not have the powers to do so at this time. The Government will continue to... Yeah, indeed.
Lewis MacDonald.
I'm grateful to the Minister and I acknowledge the points he makes. Does he accept that it is for a parliamentary committee to determine how to interpret its remit rather than for the Government? And does he accept that where the Scottish Government has an input to UK-wide discussions, it's entirely legitimate for us to hold you to account for that?
Minister.
Indeed, and I was just about to make that point in terms of the discussion we have with the UK Government. In terms of the remit, of course, it is absolutely up for the committee to set out its remit. I think the point I was making that perhaps the report goes beyond the remit as stated, and people engaged with the committee and not just government on the basis of the remit which was published and advertised. And the point I think I'm making is perhaps the report goes to other places. But you're absolutely right, that is a matter that the committee is of course, it's for the committee to decide on that, which is why I was very clear to make that was our view. And so I hope that's clear. But in terms of the discussions with the UK Government, we will of course continue to speak up for and protect the people of Scotland in discussions with our UK counterparts. However, again, it is our view that the report represents such issues unfairly and doesn't capture the nuances of reserved and devolved responsibilities fully. And I'd now move on to some of the key themes identified in the report. On the topic of research and development, we welcome the therapeutic advancements in this areas, in particular the opportunity they offer to personalised medicines for individual patients and their transformative potential, offering the possibility of long-term remission. We are working to ensure that an overarching approach to considering advanced medical therapies are in place to facilitate a once-for-Scotland approach wherever possible. That includes horizon scanning, payment models and budgetary planning considerations. On licensing and acceptance of new medicines, as the committee will know, that the regulation for the licensing of medicines is currently reserved to the UK Government, and it's the responsibility of the Medicines and Healthcare Products Regulatory Agency. And due to the reserved nature of licensing for medicines, the Scottish Government will seek to collaborate with the UK Government and other stakeholders to encourage and incentivise company licensing. In addition to incentivising companies to submit applications for licensing, there are other opportunities to use licensed medicines out with their original indication where there is a clinical need, such as off-label use. And the report notes an off-label cancer medicines programme supported by Healthcare Improvement Scotland. We published to provide advice to NHS Board Area Drug and Therapeutics Committees on the managed entry of off-label uses of cancer medicines. The learning from cancer medicines will, of course, be used to inform awareness and improve quality of governance of off-label use for other medicines. The Scottish Government will initiate discussions with the UK Government and the Medicines and Healthcare Products Regulatory Agency on streamlining and shortening the process for additional licences and healthcare technology assessments for new indications for existing drugs. The report raises issues on purchasing and procurement, and again, the regulation over this activity is a matter reserved to the UK Government. However, again, it's a Scottish Government policy objective to achieve, within devolved competence, the best possible prices for medicines. And while medicine pricing is reserved and regulated through the UK Voluntary Pricing and Access Scheme, a key objective that was achieved during the scheme's negotiations was to establish binding commitments on governments across the UK and the pharmaceutical industry to greater transparency and parity in medicine pricing. The Scottish Government is pleased to see an explicit undertaking in the new agreement that the detail of national commercial arrangements agreed in one country will be made available on a confidential basis to the other purchasing authorities in the UK. Through better practices in the area of prescribing, dispensing and consumption, a significant reduction in waste and cost can be generated by better medicines use. At patient level, caring for patients with multi-morbidities is an increasing global challenge, and a number of prescribing strategies have been published which lead to structured reviews of appropriateness, efficacy, tolerability and treatment. Presiding Officer, the inquiry references many of the findings of the 2016 Independent Montgomery Review of Access to New Medicines, and we should note that many of the recommendations of the Montgomery Review have already been implemented and steady progress has been made on the remaining ones. Presiding Officer, the convener specifically took some time talking about data, and we are evolving our approach to medicines data with a view to enhancing Scotland's international reputation in health data research. A recommendation in Dr Montgomery's review of access to new medicines is to develop, agree and implement a national cancer data set, and the Cancer Medicines Outcomes Programme is a vital first step towards achieving that. In conclusion, Presiding Officer, good progress is being made across Scotland to improve the management of supply and demand for medicines, the intended focus of this inquiry as just described. And we have already significantly increased access to new medicines due to our reforms in recent years, and I look forward to continuing to work with the committee constructively to continue to make progress. Thank you.
Thank you. Just to say there is a little time in hand for interventions. I now call Donald Cameron to open the Conservatives. Mr Cameron, please.
Thank you, Deputy Presiding Officer. Can I begin by referring to my register of interest, specifically relating to health technologies and pharmaceuticals? Can I thank the Health and Sport Committee for this very thorough and detailed report, especially the members and clerks of that committee. Having joined the committee in September, I didn't participate in either the evidence sessions or the actual report itself, but I, of course, subscribe to its findings along with other committees, along with other colleagues, as I now do sit on that committee. It is a particularly robust report, and while the Scottish Conservatives broadly welcome its findings, we acknowledge that a wider debate needs to occur in relation to its recommendations. And I've also briefly looked at the Scottish Government's response to the report that was received yesterday, which I do find disappointing that it hasn't responded more positively. I also have to say it is inexcusable that the Scottish Government's full response only emerged a day before this debate, leaving precious little time for that to be digested and properly considered before we can debate it today. As the convener alluded in his opening remarks, the inquiry focused on the management of the medicines budget, including the clinical and cost effectiveness of prescribing, and it honed in on the four key areas of purchasing and procurement, prescribing, dispensing and consumption. And I'll try to cover parts of these areas in this speech. The report was scathing about what it described as the dismal failure of the NHS in Scotland to implement comprehensive IT systems which maximise the use of patient data to provide a better service. And it went on to state that where a lack of patient focus was acknowledged, this was not followed by a solution or plan to take action, but simply left hanging for us to add to the list of issues with medicine management. And in my view, the report rightly called for a need to have a consistent and uniform IT systems in operation. And the Royal College of GPs argued that IT systems need to be improved in terms of reliability, speed, interoperability, to allow healthcare professionals working in different parts of the system to share data quickly and safely. And we agree with these findings. It is clear there is an urgent need to drastically improve our IT systems in the NHS, which appear to be well behind systems used elsewhere in the UK. The report also noted that significant action is required on reducing waste associated with the consumption of medicine, and it had several concerns in this area, including over-ordering by patients, prescription of drugs which are ultimately ineffective, patients failing to adhere to prescriptions, and medicines that have been prescribed and dispensed, which are then not taken and cannot be brought back into stock. And it cited a PwC report commissioned in 2016, which noted that an estimated 50% of patients do not take medicines as directed. Half of patients. That is a worrying figure. And aside from the obvious concern that patients in that position are not fully benefiting from treatment, it is also a colossal waste of resources and is something that the NHS in Scotland must tackle. That has been identified as a long-standing problem. The committee also urged the Scottish Government to work more closely with pharmacists to help improve adherence, and the BMA argued that health technologies could be better utilised, including the use of dosette boxes, apps and text messages as a means of reminding people to take their prescribed medication. Another interesting suggestion which came up in the report that should be considered include that of AstraZeneca, who noted in working for NHS Greater Glasgow and Clyde it wanted to introduce a smart inhaler and link this to an app that would help patients keep to their prescribed regimen. Or the University of Strathclyde, who said that new sensor and monitoring technologies will enable key stakeholders from healthcare professionals through to the pharma producers to engage more effectively with patients. The report also raises issues around prescribing, arguing that the prescriber in Scotland wields immense power when it comes to making clinically and cost-effective decisions as to which medicines to provide. And the committee took evidence which suggested, and I quote, that because prescribers have a significant degree of clinical independence to respond to patients' needs, the system cannot ensure patients receive the most clinically and cost-effective treatments. And perhaps most controversially, the committee said that prescribers are instinctively reaching for the prescription pad and are not taking the time to discuss medicines with patients. And that has turned out to be a particularly controversial statement. And I note the comments from the BMA, who say that this is an unfair characterisation and that any return to a system of incentivising particular actions accompanied with a high degree of scrutiny would be a substantial backward step. Now, that is clearly a difficult area, and it requires further discussion between the Scottish Government, between the NHS and prescribers. Yes, of course.
Emma Harper.
Would Donald Cameron agree that the BMA were very sensitive about the comments about reaching for the prescription pad, but that some work has already been undertaken to look at improving aspects where pharmacists are now embedded in GP practices so that they can better look at polypharmacy, for instance, as a way forward?
Donald Cameron.
Well, I certainly acknowledge the point about the BMA sensitivity, and that has to be acknowledged and accepted by us all, because you know, it is clearly difficult and there's a tension there. In terms of what Emma Harper talks about relating to what work is being done, I accept that work is being done, but I think the broad view of the committee was that more needs to be done. More needs to be done here. The committee argued, for instance, that the Scottish Government should examine the lack of leadership, as Lewis MacDonald said, in proposing innovative, coherent and comprehensive solutions which would deliver efficiencies and savings within the system, suggesting that little detail was offered as to how change might actually be brought about. And to conclude, Deputy Presiding Officer, although much of the report is understandably critical of many of the current systems in place, it is also a report which suggests solutions, several solutions and recommendations. And it is a report that, in my view, marks an important milestone in this debate and signals a starting point for further dialogue with those in NHS Scotland and within the government and the various representative organisations about the way forward. Let's hope this report does not gather dust, but acts as a spur to action. And can I close by reiterating my thanks to colleagues on the committee for their work, for the clerks. And while no recommendation is set in stone, I do urge the government and the Minister to take this report seriously and work proactively to ensure that policy around medicines works for patients first and foremost.
Thank you very much, Mr Cameron. I now call on David Stewart to open for Labour. Mr Stewart, please.
Thank you, Presiding Officer, and I'm very pleased to be opening for Labour on this important committee debate on the supply and demand for medicines. As a member of the Health and Sport Committee, I read all the evidence and was present for all the witness sessions which formed the basis for our report. The report, as we've heard, is comprehensive and it is hard-hitting. It does not pull its punches to the Scottish Government, and I hope that a full response from the Government would have been received in ample time for this debate and not at the 11th hour. Perhaps the Ministers could explain and apologise for the delay and also clarify why the Scottish Government felt the committee had gone beyond the remit of the inquiry. This is not the Government's role and crosses the line over of the independence that Parliament provides rightly to committees. As the convener and Donald Cameron have pointed out, the key point from the report is the system for supply and demand for medicines in Scotland does not have focus on patients. The report provides a damning analysis for the above assertion that the service is burdened by market forces and administrative bureaucracy, with reported under-resourcing, inconsistent leadership and almost complete absence of usable data. Further, and I quote the report, the impact on individual patients of taking medicines has not been examined, and worse, it is not routinely sought. The committee found few, if any, detail of any practical steps to achieve change. Gaps were identified. Why was there little mention of IGBs in the solution? And the common and recurring theme was the almost complete failure of the NHS to implement and manage comprehensive IT systems. The committee, as the convener said, took a very keen interest and saw the potential of HEPNA, that's the Hospital Electronic Prescribing Administrative System. There are obvious and clear benefits to the system, which collects and shares data on prescribing, such as improving the quality of prescribing, a reduction of errors between primary and secondary care, and removing the manual audits of prescriptions, which are, of course, very resource-intensive for staff. The wider issue is that it allows data comparisons across all hospitals in Scotland. That allows improved management intelligence so that outliers can be identified and performance improved. So I believe that means better services for patients and more efficient use of resources. It might also fight geographic inequality. Now, the Scottish Government have made it clear that since their 2017 pharmaceutical strategy document was published, that they're committed to implementing HEPNA in every NHS board. However, as the committee noted, progress has been disappointing. Some boards have not yet started with their excessive 5-year timescale to implement a system developed already in other areas. And of course, it's for each individual health board to procure and implement its own version of HEPNA. That appears to me to be inefficient and doesn't allow for economies of scale that would be part of a national procurement exercise. As the report said, and I quote, "In light of the benefits, it's disappointing to learn the rollout of this system across Scotland is patchy, slow, and proceeding at a snail's pace, with a variety of systems being considered and individually designed and procured." Moving on, Presiding Officer, to social prescribing. This, of course, is a key area and was subject to a separate inquiry by the committee. A number of submissions suggested there was a culture of reaching for a prescription pad whilst failing to explore alternative options which might be safer and have more long-term gains for patients. A Gyle and Bute Health and Social Care Partnership suggested that not all GPs support the concept of social prescribing. Some GPs argue that there's a lack of strong evidence making a clear link to long-term gains of social prescribing. And I think, Presiding Officer, we have to be realistic about the current landscape. Both the BMA and individual GPs, certainly that I've met, would argue that they're under tremendous time pressures, stresses and demands placed on our practices during the COVID-19 pandemic. But the evidence suggests that a cultural change was needed to achieve higher levels of social prescribing. And as Rosemary Parr, the Chief Pharmaceutical Officer, the Scottish Government said, and I quote, "We can educate people to not think that a prescription is the first thing. We have to look at not just self-care, but aspects of talking therapies and social prescribing. That involves a mindset change for patients and the public." So I would welcome the Minister's view and the Scottish Government's view on how they propose to manage the change so that social prescribing is perceived as an equal partner to the prescription pad. In conclusion, this report is an important and vital contribution to the medicines debate. The committee is providing a valuable service to the Scottish Government on a number of areas, not least social prescribing, HEPNA and the comprehensive review of IT systems. That, after all, is the role of committees in Parliament, to keep the executive in check and provide advice, guidance and assistance. And as Benjamin Franklin famously said, the best doctor gives the least medicines.
Thank you very much, Mr Stewart. Now I'll call Alec Cole-Hamilton to open for the Liberal Democrats. Mr Cole-Hamilton, please.
Thank you very much indeed, Deputy Presiding Officer. And can I start by sharing the concern expressed by other members of the committee at the very late hour and the contemptuous nature of the government's response to our inquiry, and particularly the suggestion that we have indulged in mission creep here. I don't think it's for government to tell committees of this Parliament how to conduct their business. Presiding Officer, it's very easy to take for granted the health advantages we now enjoy, such as the eradication of smallpox or whooping cough vaccine given to pregnant mothers, protecting babies before they're even born. Modern medicine doesn't just save people's lives, it can totally transform them. Now, you may remember a constituent of mine, Murray Gray, who turned 8 in August. Murray suffered many violent epileptic seizures every single day due to a rare form of epilepsy. At first, clinicians tried several existing medicines in an effort to treat him. Sadly, Murray suffered even more with horrible side effects. Sodium valproate caused a blood disorder when he wasn't producing enough red blood cells. Steroids caused him to gain 2 stone in weight in just 3 months. And then Epidiolex, a cannabis derivative, caused serious diarrhea all day and didn't even stop the seizures. He missed school and the fun of childhood he should have been enjoying. His mother, Karen, dedicated herself to researching a better way. And she found that another cannabis derivative, Bedrocan, was a game changer. He has now not had a seizure for over 1.5 years and is a happy boy who's returned to healthy weight, enjoying school, but entirely bankrolled by his parents because this is not legally prescribable at this moment. And whilst the legislation of medical cannabis is a debate I would hope to see soon, that's for another day. My point is, this illustrates the difficulty of when our medicine supply system is not patient-focused or it gets entangled in other wider criminal justice issues or is indeed market-driven. So whilst we've come a long way, we can certainly do a lot better. As science better understands how we can treat illnesses and disease, we need to be fleet of foot in supply of better drugs whilst making sure we get good value for the taxpayer and good treatment for the patient. I'd like to thank all of those, including those from health board staff and the medical industry workers who came to present evidence to the committee, which ultimately led to the publication of this report in June. The Scottish Government did respond to our report, but not in the depth we would have wanted and all of the findings that we would have hoped for. So when we finally got a more detailed reply to our recommendations yesterday afternoon, I was disappointed, as I said at the start of my remarks, as to the tone from the government and the rejection of our recommendations. Now, I don't agree that the committee went above and beyond its remit. I'm surprised the government felt it had to suggest that we did. The fact that this committee has put forward a total of 129 recommendations in and of itself shows the scale of change that is required. This is not tinkering at the edges. We need some creative and bold long-term strategy thinking if we are to update the current way we supply our medicines and improve the patient experience and the working practices for staff. I don't have time to cover all the ground or all of the recommendations, so I'd like to focus the remainder of my remarks on a few areas of concern to me. I think it's incumbent on politicians of all stripes to grow policy from an evidence base. Without good data, you won't get good practice. Unfortunately, that is the diagnosis for one of the main problems we face just now. If there's one thing the Scottish Government could choose above all things from this report, it would be to start gathering information about the experience people have taking medicines and analyse and share this information in a comprehensive fashion across our territorial health boards. We've got 14 of them. Managing them is hugely complex. But there's no need to operate in silos when it comes to good practice around medicines. If we are able to take a whole systems approach, it benefits primary care to share pilot schemes and data gathered so that we not only share the workload, but ensure that there's not a patchy patient experience across the whole of the country. And the more up-to-date care is rolled out wherever possible. For example, when asked about how often repeat prescriptions are reviewed, Dr. Scott Jameson from the Royal College of General Practitioners said in his evidence to the committee, and I quote, "I do not know whether we have data on that at a national level. In primary care, it's an expectation of long-term condition care that medicines are regularly reviewed. I can say with confidence that that happens. Is there always the time to have the conversations that we would value? I cannot speak for every colleague in Scotland, so I cannot say whether that is the case." This shows the downside of squeezing in 10 minutes appointment into the working day of general practice. Our average appointment lasts 9.2 minutes, which is one of the lowest average appointments for economically advanced countries in the world. Sweden averaged 22 minutes for a consultation. And if we can alter the system so that GPs can routinely offer 15-minute appointments, they might be afforded more time to discuss important matters, such as reviewing long-term prescriptions. And I think that some of the IT developments has brought by necessity in this pandemic through GP Near Me and online appointments could go some way to allowing us that objective. Speaking of GPs, we know from our casework at a constituency level that many parts of this country need more of them. But even with the Scottish Government's commitment to deliver a total of 800 additional GPs by 2027, there will still be a shortfall of more than 600. So in conclusion, Presiding Officer, I'd say this: investing in the workforce, planning and looking to upgrade how much of data we gather around patient experience and a real investment in better IT systems will help our beloved NHS handle the challenges of the demand and supply of medicines. Thank you.
Thank you very much, Mr Cole-Hamilton. The open debate, I call George Adam to follow by Miles Briggs. Mr Adam, please.
Thank you, Presiding Officer. Presiding Officer, this inquiry was one of particular interest to me for a number of reasons. And initially, to start off with, I'd probably like to go over some of the things that have been said by my colleagues already. Like David Stewart already spoke about, we worked in tandem about social prescribing at the time. And one of the concerning things for us, and the BMA might not like it, but one of the concerning things is that they were reaching for the prescription pad rather than actually try and deal with the issue in the person themselves. And it's one of the criticisms it's meant to the BMA and to GPs with great love and affection, just say there are other ways to actually deal with these situations. And if we look at this report as well, we have to look at the timeline of what's actually happened. Because, Presiding Officer, when you look at the timeline, none of our evidence was taken after the COVID-19 pandemic started. So we know in the committee that many barriers that were in the way have actually come down and things have been a lot easier for people to work across the service as well. So if we had the same inquiry now, we may see some of the issues that were obvious then not so obvious now. But the thing would be now we have to be in a position that post-COVID that we can actually deal with that as well. And many of you will know, Presiding Officer, that one of the other reasons for me with access to medicine is because my wife Stacey with multiple sclerosis, and some of the work that I do with the cross-party group in MS. I'm quite sure colleagues on the committee are absolutely sick of hearing various stories of Stacey's adventures through navigating the National Health Service, but I now and again manage to get a few of them in, because the problems as I see it for conditions like multiple sclerosis and probably other complex conditions is their very complexity. And large pharmaceutical companies will say it takes years to research the cost, and it costs them an almighty, a shed load of money. However, they more than make up for their costs when they license the products and they go to market. And then we have the decision as to whether the medicines can actually do what these big pharma companies say they can. There is also the cost, which can be astronomical, and the SMC needs to make the very difficult decision on whether the results are worth the cost. This isn't helped by the fact that big pharmaceutical firms have gone on full sales mode by that stage and promised the earth to those living with long-term conditions. During our inquiry, I also kept asking about branded and unbranded products. Branded being the new shiny generic state-of-the-art expensive new products, and unbranded generic medicines are those that the companies no longer making massive amount of money on and no longer licensed. And there's many consultants within the world of MS are looking at these unbranded products as a way of managing the condition, and they're looking at it for other conditions as well, because obviously there's the advantage that it will be cheaper than the branded product themselves, but it's also the fact that there's ones that maybe have been used for another condition can now be used for something else. And these are the things that they're looking at. But there's a resistance from the industry with regards to this, because for them, the big money is in the shiny new product. And I can understand why they would want to do this. Yes, I will.
Neil Findlay.
I wonder if the member would agree with me. I've long believed that for the creation of these unbranded drugs that we should have a state provision of that, and that the state should actually produce these centrally and drive down the cost so that we're not being ripped off by pharmaceutical companies.
George Adam.
Perhaps that's a debate we should continue to have, and I think this actual report is the starting point for that, because I think this is one of the issues that we're dealing with, because at the end of the day, it's people's lives and it's how they get on with that life that's the problem. And, you know, I'm not saying there isn't a space for new medicines that can make similar differences to people's lives. The world has moved on quite a bit considerably, with COVID-19 being the main topic in everyone's conversations. But in this case, it appears that large pharmaceutical companies have come up trumps with a vaccine. And all I'm saying is that we need to find a balance. We need to find a way where we can actually balance this out, because currently the balance is on the vast majority being about the branded products themselves. In 2018-19, NHS Scotland spent around £1.7 billion in medicines, and most medicines were dispensed within the community at just over 103 million items, at a cost of around £1.3 billion. Although the total number of items that are dispensed to patients have steadily increased over the past decade, we have seen a fall of £6 million in the net cost of the medicines from 2017-2018. So this surely is an example of how the Scottish Government is dealing with this issue and moving forward. There is also the fact that the Scottish Government has made progress in the collection and use of data to improve patient outcomes, particularly in primary care. But it's important that we move this further on, Presiding Officer. We have to make sure that we have the data available for individuals so that the individuals are getting the right medication at the right time, and for the health boards and everyone else, it is the right cost. Because one of the important issues that continued to come up during our inquiry was the need to significantly reduce waste and costs by generating better use of medicines. And NHS Discovery provides comparative healthcare information for quality improvement, benchmarking, performance and management across the NHS in Scotland. And we need to make sure that these barriers continue to come down. And if one thing, Presiding Officer, in closing, that COVID-19 has possibly taught us is that we can make this work. We can make these things happen. We can bring down these barriers. And I would say that when we're looking at this report, there is work for the Scottish Government, there's work for us to do. But let's remember, we're living in a brave new world and things are completely different from when we made this report. And we need to look at that when we're dealing with this. But use this report as the basis to have the debate from here on in.
Thank you. I call Miles Briggs, to be followed by Lane Smith. Mr Briggs, please.
Thank you, Deputy Presiding Officer. I'm pleased to take part in this afternoon's debate, having served on the Health and Sport Committee during the time the committee undertook this important inquiry into the supply and demand for medicines. The inquiry focused on a number of themes, notably the need to use data more effectively and the desire to monitor patients' outcomes in order to reduce waste and increase efficiency. And it's on that point which I want to concentrate my remarks today. As Alex Cole-Hamilton has said already, the key message that was given loud and clear from all those who actually gave evidence to the committee was overwhelmingly that data is king, and that improving the collection and understanding of outcomes-focused data was critical to be able to improve patient care and to deliver a sustainable NHS. Now, we know that the NHS's ability to track certain patient conditions, and particularly how medicines are impacting on them, is really limited. And the ability to accurately capture patient outcomes and experiences is still a major challenge. And although some welcome progress has been made, there's still a real need to see a commitment and renewed focus from the government to actually achieve this. And I hope the Minister, in listening to contributions today, if there's one thing the Minister will take away, it is that call for data to be given a priority going forward by the government, because tracking a patient's care from initial presentation in primary care through to treatment and discharge from secondary care, whilst measuring any social care implications, would be incredibly valuable to both the NHS, patients and their families and carers. Capturing and using this data will enable the health service to drive even greater efficiencies and for the medicines budgets to be utilised better. The use of flexible commercial arrangements with industry to connect the price of a medicine more closely with its real-world performance, I think something we really should see progress on. Reduced medicines wastage through the identification of inappropriate prescribing and increased adherence, as Donald Cameron outlined, is also vital. And fewer hospital admissions, delayed discharges and the ability to treat more patients in the community through the use of preventative treatments, and perhaps more controversially, the ability to address the over-treatment of individuals in our health service and the actual delivery of realistic medicine in practice. As the co-chair of the Scottish Parliament's cross-party group on cancer, I'd like to put on record some of the concerns which have been put to me by a number of the group's members, really relating specifically to the lack of data currently being collected on secondary breast cancer patients in Scotland. Many believe that improvements to collection of outcome data will deliver real benefits, including refined treatment pathways to ensure medicines are better matched to patients in Scotland, and increased use of complex patient access schemes to enable faster access to the latest treatments and perhaps most importantly to improve pathways to clinical trials. I hope the Minister will take on board this ask and agree to review the current lack of data collection for secondary breast cancer patients in Scotland, and he'll address this specifically in his closing remarks tonight. The Cancer Research UK stated in their briefing ahead of today's debate that every person diagnosed with cancer in Scotland should have equitable access to the best evidence-based treatments for their condition, and I agree. The impact of the pandemic on our NHS cannot be underestimated, as George Admin has already outlined today. And from what I have been told by patients, it's likely that we will see a significant negative impact on access to clinical trials going forward, which we've already seen over the last 9 months. My greatest concern is that the significant progress we've made to date on cancer treatments and the improvement of cancer outcomes will have been undermined during this period and will be negatively impacted for years to come. That is why I set out at the start of the pandemic and lobbied ministers to start to develop urgently plans to restart cancer services and screening. Perhaps most importantly, as we come out of this pandemic, is actually the need to address some of the known health inequalities which also exist around hard-to-reach patients and lower screening attendance. And I hope that's something ministers will be urgently looking to act upon to address these growing concerns within the cancer sector in Scotland. The committee's recommendations in the inquiry into supply of and demand for medicines are important, and I hope ministers will genuinely look at what the committee put forward and press ahead with the concerns which we outlined, regardless of the pressures the pandemic has presented to government. To date, we have seen delays in progressing innovative pricing arrangements, outcomes-based reimbursement. I understand that the Scottish Government is actually still yet to involve industry or establish a task group to drive progress in these areas. So we need to see progress urgently to ensure NHS Scotland can access new drugs and treatments, which we are now starting to see on the horizon. Our Scottish NHS must be able to achieve value for money, and it makes sense for a system to make sure that the NHS is paying for the medicines where there's actually evidence of clinical improvement and quality of life benefit to patients, while ensuring that industry genuinely can be involved in breakthroughs which will continue to be rewarded, and the patients at the end of the day will gain from that. To ensure best outcomes for patients, Healthcare Improvement Scotland should endorse NICE clinical guidelines, whilst up-to-date sign guidelines are on hold because of the pandemic. To conclude, Deputy Presiding Officer, the global COVID-19 pandemic has demonstrated, I believe, the positive relationship which can exist between governments and the pharmaceutical industry when sensational work which we have seen to develop and take forward work for the COVID-19 vaccines is just the example of the sort of pioneering, rapid progress we all want to see. More flexible medicine pricing schemes, such as outcome-based payments, must be taken forward to offer an opportunity for NHS Scotland to target medicine spending on these treatments where they are most clinically effective. And I hope in the spirit of working collectively to deliver for Scottish patients, we will see a new relationship developed that delivers for patients, meets the future aspirations of the medical community to deliver access to the world-leading medicines and treatments that we all want to see. Thank you.
Thank you very much, Mr Briggs. And I call Elaine Smith to be followed by David Torrance.
Thank you very much, Presiding Officer. And can I also thank the Health and Sport Committee for their report and the committee clerks and others for their work and contributions. In a short debate, there's no time to address fully the many issues in the report, nor in fact the astonishing response by the Scottish Government. They've had the committee report since June, as we've heard, but waited until the evening before the debate to inform us that, and I quote, "Whilst the Scottish Government acknowledges that the report highlights numerous important issues relating to the supply and demand for medicines, overall we believe that the report goes far beyond the published remit of the inquiry and contains misunderstandings, inaccuracies and inconsistencies." Well, given these claims, the committee should be afforded another opportunity by the Parliament to address the Government response fully, and as such the report certainly shouldn't be gathering dust, as another member said earlier. Presiding Officer, as an elected member who spent many years campaigning for better medicine choices for sufferers of thyroid disease and having a personal interest as a sufferer of Hashimoto's, and tend to consider parts of the report pertaining to issues that I have advocated on and to show the need for change. Point 1 of the executive summary of the report sums up the experience of many thyroid sufferers when it states that a fundamental problem has become apparent. The system of supply and demand for medicines in Scotland does not have a focus on patients. Unfortunately, in the case of thyroid patients, the focus recently has been very much on cost alone. Briefly summarise that problem faced by many with hypothyroidism. The most common drug prescribed is levothyroxine or T4, but at least 10% of patients are acknowledged to not do well on this treatment, and the only effective treatment for them is liothyronine or T3. This is a drug which is routinely prescribed in the rest of the world, but in 2016, the 28-day NHS cost of liothyronine increased from around £4.50 to £258.19, an increase of almost 6,000%. Concordia, who've since been under investigation by the Competition and Markets Authority for, and I quote, abusing its dominant position to overcharge the NHS by millions when supplying liothyronine, at that time had a monopoly on the sale of liothyronine in the UK. In a 2019 report published in The Lancet, it was found that in NHS England, no major study or guideline has advocated a change in liothyronine prescribing, and that the substantial reduction in prescribing seemed to be largely driven by cost. There are now 3 companies producing T3, but the price remains high. Thankfully, this committee report confirms the need for greater public control over research, development, production and sale of medicines. We cannot deliver healthcare and keep to the founding principles of the NHS when profits take precedence over patients, as the T3 situation shows, and as mentioned in an intervention by my colleague Neil Finlay earlier. A not-for-profit, publicly owned pharmaceutical industry would be a good start to developing more medicines which cure conditions rather than manage symptoms. If we aim to control the medicines budget and maintain cost effectiveness, then this must be considered. I congratulate the committee for recognising the fundamental importance for greater public control, and we really have to give further attention to how an industry which is underpinned by substantial public funding for research can then sell those innovations back to us at grossly exaggerated prices. And that may be very pertinent right at the moment, Presiding Officer. Coming back specifically to thyroid issues, despite the Minister stating previously that the Scottish Government's position is that T3 can be prescribed by an endocrinologist if it is considered to be the safest and most effective course of treatment for an individual, women are still struggling to get T3 prescribed. Many have also have problems being diagnosed and in getting beyond their GP to proper consultation with an endocrinologist. And even then, they might not be offered T3 due to the postcode lottery. Another challenge for thyroid patients, who are principally women, is that the medical establishment often blames the menopause, routinely prescribes antidepressants, or just doesn't listen and properly diagnose or treat the medical condition that's being presented. Of course, finding the right solutions for patients isn't made any easier when, as the BMA points out in its response to this report, GPs are still working within the confines of 10-minute appointments due to ever-increasing demands on them. And women are left facing this additional obstacle to gaining the right treatment and prescription medicines. The inequality and disempowerment in health provision that women suffer can no longer be ignored, and we must see major change. To be able to measure that, to be able to measure progress, we need better collection of data, something I note that is recognised in the report and others have mentioned. The committee report also correctly recognises that when we determine and cost the clinical effectiveness of a patient's treatment, we must listen to the patient. The committee says that, and I quote, "There is not strict adherence to the principles of realistic medicine. Patients are not treated as equal partners in discussions on their treatments." Thyroid patients not getting the correct treatment certainly struggle to be heard, despite the fact that they need suitable prescriptions to function or even stay alive. And there is mention in the report of benefits outweighing the cost, and this is clear with thyroid patients who will struggle to work without the correct medicine, with a massive economic impact both individually and for society. Presiding Officer, many of the recommendations within the report have the potential to make great improvements for patients, but I fear that without brave and radical actions on both a UK and Scottish level, we will struggle to put patients' health at the forefront. We need many of the reforms laid out in the report to ensure that the supply and demand for medicines in Scotland does actually have a focus on patients And once again, in closing, I find it regrettable that the Government waited to the 11th hour to respond, and I thank the committee for their hard work. Thank you.
And the last of the open debate contributions is from David Torrance.
Thank you, Presiding Officer. As a member of the Health and Sport Committee, I welcome the opportunity to speak in this debate today. I would like to offer my thanks to clerks and Spice, as well as my fellow committee members, for their hard work in contributing to the supply and demand of medicines report. I'd also like to pay thanks to everyone who contributed to this inquiry and gave evidence, both written and oral, to the committee. As a committee, it is crucial that our work is informed by a wide range of experiences, needs and views, especially from those most directly affected by the issues in question. It is vital that we hear a range of diverse comments and thoughts from a wide range of backgrounds. I was pleased to see the level of engagement and views from an extensive range of bodies and individuals in response to our call for submissions late last year. It is only by listening to all these voices that we can effect real and meaningful change. As we have heard, the focus of the committee's inquiries was on 4 specific areas: purchasing, prescribing, dispensing and consumption. For an annual spend of in 2018-19 of around £1.7 billion on medicines by NHS Scotland, most of which was dispensed in the community, you can see just how important it is that health service, general practitioners, pharmacists all work to deliver effective prescribing for patients. The number of items issued in the community has steadily increased over the past decade, from 89.3 million items in 2009-10 to 103.4 million items in 2018-19. It's testament to the work of those healthcare professionals that despite this increase over the last decade in the total number of items dispensed to patients, there was a fall of 6 million in the net cost of medicines from 2017 to 18. As a Fife MSP, I was particularly interested to read the written submission of a committee from NHS Fife Area Drug and Therapeutics Committee, which noted the often preferred route for other non-pharmacological treatment options, whilst acknowledging access to those resources can frequently be limited, constrained and challenging. This committee has recently reported on a separate inquiry into social prescribing, and this subject has continued to be prevalent during our work in medicines. A number of submissions suggested a culture of instinctively reaching for a prescription pad, while failing to explore alternative options, which could be safer for patients and represent cost savings for the NHS. Speaking on the subject of social prescribing, the Scottish Government's Chief Pharmaceutical Officer says, "We can educate people not to think that prescription is the first thing. We have to look at not just self-care, but aspects of talking therapies and social prescribing. That involves a mindset change for patients and the public and a discussion about the needs to happen. This is an important point and must continue to be addressed. The links between the benefits of physical activity to improving our overall health and well-being are well documented and widely acknowledged. At this time, medicines are the most common intervention in our healthcare system, so it is important that we get the most from them, for patients and for the NHS. It is clear that a significant reduction in waste and costs can be generated by a better medicine use. It is vital that we challenge inappropriate prescribing, over-prescribing and waste. A substantial component of waste is where medication is not taken or prescribed, often referred to as non-adherence. In Fife, this problem has been acknowledged and a positive action taken to reduce the estimated 2.1 million total annual cost of medicine waste, including public and staff take stock communication campaign, non-prescription order model introduced for selected products, improved care home medicine returns process, a test of pharmacy support workers in 12 care homes to support ordering process, a one-stop dispensing model introduced to hospital settings, and the visits are also being carried out with GPs and pharmacists to look at residents' medication, thereby not only saving on waste, but the deprescribing and consideration of what a patient is on can also make a huge difference to their safety and well-being, their frailty and their ability to be better aware of what is going on around them and improve their general quality of life. The Fife submission also highlighted desire by the boards to treat people closer to home in a more patient-centred manner by working with companies to make higher costs of more specialised medicines available through local community pharmacy networks, rather than the patient travelling often to what can be considered distant to acute hospitals to access treatment. I would strongly agree that any strategy that seeks to reduce demand by promoting greater patients' involvement in their treatment is far more promising than adding more financial resource to meet an ever-increasing demand. Scotland is leading the way in community pharmacy service provision. Our community pharmacists are most accessible primary care provider, with 1,257 pharmacies all over Scotland and with a higher concentration of pharmacies in deprived and highly populated areas. There is also a good place to have conversations about use of medicine, where people are taking their medication, and if not, why are they still getting them dispensed? There is also an issue of communication and ensuring the right messages get to the right people. It was interesting to hear this highlighted during an evidence gathering session by Claire Fernie, who is a public partner volunteer with NHS 5. Claire discussed the impact which the absence of joined-up approach has on clinical and cost-effectiveness, particularly with respect to IT systems and availability of information between general practice, community practices and hospital services. As we make progress, effective communication is key as we move away from only doctors having prescribing powers to an increasing number of health professions. We will only achieve an integrated approach that is both consistent and relevant if a conversation is broad and inclusive. In conclusion, Presiding Officer, I welcome the report, its recommendations as well as the response of the Scottish Government. I welcome the progress that has already been made in collection and use of data to improve patient outcomes, particularly in the cancer treatment and in primary care, and look forward to a continuing commitment of the Scottish Government to improving the health and well-being of people and communities across Scotland.
Thank you. We'll now move to the closing speeches, and I would hope that those who took part in the debate in the chamber will shortly be back in the chamber. And we have a wee bit of time spare, so interventions and things are fine. And first of all, call on David Stewart for a generous 6 minutes, please, Mr. Stewart.
Thank you so much, Presiding Officer. And this has been an excellent debate with considered and thoughtful contributions from across the chamber. I had assumed in advance that this would be a warm and consensual afternoon's discussion around the supply and demand of medicines. However, it would be fair to say that the Scottish Government's 11th hour response to our committee's deliberation caused some ripples in the calm waters of this debate. The Scottish Government say that the committee have gone beyond the remit of the inquiry and strayed into reserved areas, but they have ignored our main findings, the lack of patient focus within the NHS medicine structure. And as the convener, Lewis MacDonald, said, of course, scrutiny is the heart of our task in the committee structure. Our job, that's the committee's job, is to ask the difficult and searching questions and to shine a light on the costs. He identified the 1.8 billion cost of medicines. Half of all medicines are not consumed correctly, and the committee had a duty, rightly, to follow the evidence. Donald Cameron made some very appropriate comments. He also thought it was a thorough and detailed response, and he did subscribe to its findings. And of course, he's a member of the committee himself now. He also felt it was disappointing that the Scottish Government report only appeared a day before this debate. Donald Cameron was scathing about the IT reforms and about the lack of patient focus. And what is needed is a consistent approach in the area of IT. Alec Cole-Hamilton made a very strong point that there was no question of mission creep, his words, as far as the committee structure was concerned. He made a strong speech with a vivid example of a constituency case involving medical cannabis. He made the very strong argument that we need better drugs at good value to the taxpayer, and of course the key is that benefit our patients. And he finally said that with 129 recommendations, it shows the scale and the scope of the problem. George Adam made some very strong points about social prescribing, the very important way, other way of dealing with prescribing generally, and of course talked of his own experience in the CPG of MS and the experience firsthand with his wife Stacey. He also talked about the very important distinction between branded and unbranded drugs and the key issue around the licensing regime. Miles Briggs talked about data being the king, and of course it helps patient care, and the ability to capture patients' outcomes is crucial and challenging. And Elaine Smith talked about the astonishing delay in the government's response to the report, and of course Elaine Smith's well recognised for her campaigning work in the area of thyroid sufferers. So in conclusion, Presiding Officer, I believe this has been an excellent debate, and I want to echo the convener's thanks to our witnesses and to the clerks for this very comprehensive piece of work. I have always felt in this Parliament that the great strengths of our committee structure is it keeps the executive in check, irrespective of who the executive might be, and provides advice, guidance and assistance to government. And I believe that the philosophy
logging on to solutions at the moment.
I believe that the philosophy of all committees are reflected in the words of Michael Spector, who said, "Be sceptical, ask questions, demand proof, demand evidence, don't take anything for granted." But here's the thing, when you get proof, you need to accept the proof, and we're not that good at doing that. Thank you, Presiding Officer.
Thank you, Mr Stewart. I'm unaware what that interruption was, but apologies if it was at this end. We now go to Brian Whittle for around 6 minutes, please.
Thank you, Deputy Presiding Officer, and I am pleased to be closing this debate on behalf of the Scottish Conservatives. The Health and Sport Committee's report is comprehensive. I think it certainly raises issues that the Scottish Government should be taking cognizance of, many of which have been raised during this debate by members. And the convener, Lewis MacDonald, started off by highlighting, though, that the response from the Scottish Government took far too long, and it's a concern, given that the committee's scrutiny is a key driving force here in government policy. I hope it's not an indication of a Scottish Government not prepared to listen to Parliament. Unfortunately, when we heard the Minister seem to retreat into the Scottish Government bunker and seem to suggest that the Scottish Government should be telling cross-party committees what it should and should not investigate, instead of actually listening to the issues raised by a significant piece of work. Can I say to the Minister that the committee work is the foundation of our Parliament, and committee work should help to drive policy? I think the Scottish Government's response remains far from satisfactory. But given the complexity of the issues examined here, I want to focus the short time I have on a couple of key points. I think, firstly, the committee's conclusion that the system of supply and demand for medicines in Scotland does not have a focus on patients, a point raised both by Donald Cameron and David Stewart. And I think I'd like to link to that the committee's conclusion that a lack of data collection and analysis on the outcomes achieved via the prescription of medicine is of a huge concern. These are crucial points, of course, because surely the prescription of any kind of medication is to alleviate or to help a medical condition. However, there is without doubt an over-medicalisation of conditions without enough measurement of appropriate outcomes. We know there's a significant wastage in prescribed medicines, with something like 50% of prescribed medicines going unused. This is increasingly important against a prescribed medicine bill of £1.4 billion, which is an increase of over 4% in the previous year. I think to compound this, there has been an increase of over 16% in the items dispensed over the last decade. And when we're always looking for ways to improve the funding in our health service, these numbers are significant. Now, of course, the majority of these prescriptions are necessary, but without a proper and measured understanding of the effectiveness of these medicines on a patient, it is difficult to make appropriate conclusions. I think this is one of the biggest criticisms of the current system within the committee report, which states, and I quote, that we found a lack of care taken to understand people's experience of taking medicines impacted the system at every stage. We are clear that gathering and analysing and sharing information in a comprehensive, systematic way across Scotland would be the single most beneficial action as a result of this inquiry. And this kind of conclusion has actually been raised in other Health and Sport Committee investigations. That lack of an IT infrastructure and technology policy that allows for the gathering and extraction of appropriate data. To sustain quality healthcare, free at the point of need, the Scottish Government can no longer leave this unaddressed. And this takes me to the appropriateness of treatments prescribed. It would be appropriate here, I think, to link the committee's report on social prescribing, a point that George Adam made in his speech. Too often we find patients being prescribed medication without alternatives being considered. Time and again we hear evidence that tells us that an active, healthy lifestyle can have a huge impact on our physical and mental health. I think the Chamber knows that I have frequently asked the question around that access to alternatives to medicines for doctors to prescribe. We look at the symptoms, not the underlying causes in far too many cases. Obesity and type 2 diabetes, and addiction and poor mental health, COPD, musculoskeletal conditions and arthritis, and heart disease, and any combination of the above are often treatable or even preventable, but we don't always give our healthcare professionals the tools for their tool bag that they could use. This is not a new issue, but there is a lack of leadership and will to make the changes from the Scottish Government. If I could look at the prescription, for example, of antidepressants for those suffering anxiety or methadone for those suffering addiction as two specific illustrations. We hear evidence over and over again that patients are remaining on these medications for too long without a treatment plan and that reduces the patient's need to remain on that medication. There's key points I would like to make here. Number one, I think that prescribed medicines, that we must ensure that prescribed medicines are having the impact on patients that they are prescribed for. That requires an IT infrastructure that can follow the patient. The HEPNA system in secondary healthcare is beginning to be rolled out across certain health boards, and early indications are that in hospital pharmacies will have a positive impact on delayed discharge. However, once a patient leaves hospital and moves into the jurisdiction of primary care, that recording of the prescription does not follow them, and I think that's something that must change as soon as possible. I think number two, when medicines are prescribed, all other options to treat the patient are able to be considered, and that other treatments that could augment medication are prescribed to ensure that the need for that medication is minimalised and patient outcomes are of primary concern. Of course, in addressing these issues, it stands to reason that the cost of these treatments will reduce, allowing the Scottish Medical Consortium to justify the costs of more medicines, therefore opening up further treatment pathways. Deputy Presiding Officer, the Health and Sport Committee report on supply and demand of medicines is a significant body of work, and I would like to join my colleagues in thanking all those who gave evidence and the clerks for the work. It does highlight where the Scottish Government needs to go, and I hope the Scottish Government takes the report seriously and acts upon it. I would conclude, though, by suggesting that this report is only one piece in a much bigger jigsaw. Its conclusions can directly link to all other reports the committee has published and give it a three-dimensional look across the health and sport in Scotland and shape healthcare in the future. I've mentioned the social prescribing report, but we could include addiction, primary care, social care and many other investigations. Each of these reports should not be considered in isolation. As this report states, patient outcomes should be what we measure. Deputy Presiding Officer.
Now call Joe Fitzpatrick for around 7 minutes, please, Minister.
Thank you, Presiding Officer, and thank all members from all parties for their contributions. I think it has been, as David Stewart said, a good debate. I think I want to first, a number of members have mentioned the fact that the government's full response just arrived yesterday, and as Alex Cole-Hamilton said, the Cabinet Secretary did initially respond to the high-level items on the 11th of September. I'd also point out that this debate was originally going to be later in time, so had we managed to respond yesterday, then it wouldn't have been just the day before. But I recognise that while I absolutely want to put on record my thanks to all of the government officials who made sure we could get a full response to the committee before the debate today, and these are the same officials who are working day and night in making sure our COVID response is working day and night on our COVID response. But nonetheless, it was unsatisfactory for the committee, for the Parliament to receive that response just the day before the debate, and for that I do apologise. Clearly, it would have been much better had the Parliament had the opportunity to look at that for a longer period. Presiding Officer, as I said, I think it's been a good debate. It's been an informative debate, and much detailed questions about why Scotland isn't moving faster on a range of issues raised in the Health and Sport Committee's report. And let me be clear that there is no lack of ambition in this government regarding the supply and demand of medicines. As I've noted earlier, the current devolution settlement does not provide Scottish ministers with the full powers to act in many of the areas highlighted by the committee's report. However, we remain fully committed to progressing this important area as far as possible within our devolved powers and with the context of increasing capacity constraints as a result of COVID-19 pandemic. I was struck by one of the points that George Adam made in his contribution, and he made the point rightly that most of the evidence had been gathered before COVID-19 pandemic. And he also made the point that the COVID pandemic had seemed to perhaps oil some of the wheels, and that some progress had been made during the pandemic on a number of these issues. I think it's unfortunate. I absolutely understand the constraints that committees are under in terms of the timescale, but I think it's maybe unfortunate that some of that didn't appear in the committee report, because I know that a number of the folk who are working really hard across our NHS service felt, and I recognise this was not the intention, but felt that the report was unduly critical of them. So it was good to hear that the words from the convener at the start, and also George Adams' recognition that progress, in spite of all the challenges of COVID-19, progress has been made. And I think that is helpful. Convener.
Thank you very much. MacDonald. Thank you for taking a further intervention, Minister. I think the point I would want to reiterate is that what the committee wanted to do was to draw attention to the shortcomings in the health and care systems. That is not an attempt to demean or take away from the fantastic work that is done by our health and care workers, but nonetheless it remains critically important that government and leadership within the NHS is willing and able to take on board constructive criticism that can improve services.
Joe Fitzpatrick.
Yeah, and I think today's debate will help people do that, because I think it's been a much more balanced debate, and I think there's recognition of because I think when we're talking about the NHS, it is really important that we remember all levels of the NHS, including the leadership. These folk at all levels in our NHS have been working tirelessly for months now, and they really need our support. I think just to recognise this report came out just as they were coming out of the toughest part of that. However, I think on balance, as I say, today's debate has been positive, and I'm sure it will be taken in that term. Donald Cameron and others spent a bit of time talking about medicines data, and I can assure members that we are fully committed to improving data and recognising the benefits of real-world data to improve patient outcomes. We've been taking a phased approach to improving data systems in Scotland, and it's important to ensure systems are in place, but equally it requires cultural change, staff changes and understanding of real-world application. So steady progress will be the key, and ensuring we bring stakeholders with us. The programme for government announced a refresh of our digital health and care strategy in spring 2021, followed by our first data strategy, both of which will set out our plans for making Scotland a leader in how it captures and utilises data to the benefit of patient care. And I think that's always got to be central. The convener and Mr Stewart both went on to specifically ask about the HIPMA system, and officials continue to work with health boards to ensure a local and regional approach to delivery across all of our boards to support this, as we've established the National HIPAA Implementation Oversight Board. So good progress is being made, and I think to put that into context, for right in the middle of the point. So let me finish the point, because it may even answer what you're saying. To put that into context of what that means for timing, obviously a number of boards are already on board. We expect the remainder boards to start implementation, to have implementation underway, not necessarily completed during next year. So that would be the time, and we'd expect it to take 2 or 3 years to get to full implementation. It's a really important piece of work, but and it's good that all boards have a pathway to that.
Brian Whittle.
Thank the Minister for taking the intervention. I think I've seen HEPNA at work in Ayrshire and Arran, and it is, as you're right, it's an incredibly important piece of work. Does the Minister agree with me, though, that what we need to have is the prescriptions in secondary healthcare follow the patient into primary healthcare, which it currently doesn't do, and that bit of work needs to be done?
The member is absolutely right, and it's one of the areas that we are making considerable progress to, that if someone gets a prescription, then any relevant person within our health system that needs to access someone's medical records at that point, it should be. We've made considerable progress in terms of the pharmacy first work, but the member is right that will make a huge difference, as we recognise that, particularly in terms of primary care, it's far wider than just the GPs and there's a range of people who work in that system, and being able to access appropriate data is really, really important. Alex Cole-Hamilton made some points around repeat prescriptions and the chronic medicine service, which was first introduced into community pharmacy in 2009, promoting a partnership approach between pharmacists and patients, and that's intended to help with that issue, and we are refreshing that process. It will be getting a new name, as well as the Medicines Care and Review Service, and a small number of enhancements to how it operates is underway. So serial prescriptions will be an important tool in the remobilisation of our NHS by supporting both GP practices and community pharmacies to more effectively manage workloads around prescriptions. Brian Whittle talked, as he often does, and rightly so, about social prescribing, and David Stewart in his contribution asked how we were going to change the culture to put non-medical treatment on a par with drugs. And in response to both members, they should be aware, I hope, that we've committed to establishing a short-life working group to examine social prescribing of physical activity, and the aim there was to identify and communicate examples of best practice and co-produce resources for practitioners in the many roles which make up the overall system. So we need to make sure that where there's best practice is happening, that is able to be shared right across our system. Elaine Smith, obviously I want to put on record my recognition of Elaine Smith's personal and long-standing work in relation to thyroid patients, and she raised the issue of T4, T3 prescribing. Presiding Officer, the Government and I have been clear to clinicians that prescribing of T3 should be based on patient need, and that cost should not be a reason not to prescribe T3. Presiding Officer, I see I'm probably about at the end of your patience. I think this has been a good debate. I think there, in spite of maybe of some of my early contributions, I think it's a good debate. I think there's a lot in this report which we can take forward in a constructive way, and I guess my assurance to the committee is that is something we intend to do. This is an area of work that government and clinicians all think is really important, so we will be sure to keep the committee updated of progress.
Thank you. I now call Emma Harper to wind up the debate on behalf of the Health and Sport Committee. For around 8 minutes, please, Ms Harper.
Okay, thank you, Presiding Officer, for confirming the timing. I welcome the opportunity to close this debate on behalf of the Health and Sport Committee as Deputy Convener, and I remind Chamber that I'm still a registered nurse. I want to thank all members, including committee members, for their contributions this afternoon, and I also want to thank the clerks and acknowledge the work that they have done in preparing for the scrutiny, for the inquiry, and for preparing the report that we are discussing today. Of course, I echo the thanks conveyed by the convener to all who provided evidence. It has been positive to have cross-party consensus on this report and on the report's extensive recommendations, on which there are 129. The report has discussed the subject of medicines in great detail. We covered areas from the point of purchase and procurement through to prescribing, dispensing and consumption. It could easily have been 4 separate reports. And I want to take this opportunity in closing today to touch on some of the key findings and recommendations from the report, and I will comment on the contributions from members. It is worth noting that the report and inquiry were largely carried out pre- and early COVID-19, so some of the practices and recommendations may have been expedited due to the challenges posed by the pandemic. It is a large report, and the committee convener and members presented much of the detail about what the report found. Person-centred approach, HEPMA, joined-up leadership approaches, supply and demand, waste and prescribing. And I welcome the Minister's comments on a Once for Scotland approach. And I know also that there is a distinction between reserved and what's reserved to Westminster matters and then what is devolved to the Scottish Government. And I agree that it is important to make it clear in any communications and reports what is reserved and what is devolved, and that will help a greater understanding for me, certainly, and I'm sure others reading the report. I also accept the Minister's apology for the late response of the report, and I would like to thank him and his officials for all of their work since COVID in the past few months. I'm sure they are all working flat out to tackle many issues that this pandemic has thrown at them all. Dave Stewart and Brian Whittle, they spoke about having a more connected hospital electronic prescribing medicines. That's the HEPMA system. And Dave Stewart mentioned that geographical inequalities may be addressed if we had a more connected HEPMA system. And Dave Stewart and Brian Whittle also spoke about social prescribing and mentioned our other report, which we focus more in detail about social prescribing. George Adam talked about it too. And many of us in the committee are keen to see progress made on further delivery of social prescribing approaches, because we've seen evidence, or we've heard evidence about how type 2 diabetes can be mitigated to the point where no type 2 meds are even required through programmes of social prescribing. Miles Briggs spoke about secondary breast cancer and access to new drugs for those persons, and I welcome his comments and his work in his cross-party group around that. Donald Cameron spoke about improvement that is required for IT systems, and I will come to that also. And Alec Cole-Hamilton talked about prescription reviews and medicine prescription reviews. And I also want to thank Donald Cameron for taking my intervention earlier. My point was to just clarify that there has been a lot happening since COVID, and we know that there is already work being undertaken embedding pharmacists in general practice. In undertaking this inquiry into supply and demand for medicines, the committee were anticipating exploring issues relating to the efficiency of the system and the levels of waste generated. It is a stark fact that 50% of medication is not taken as prescribed. And however, in considering the themes raised with us, the fundamental problem has become apparent that the system of supply and demand for medicines in Scotland does not have a focus on patients, or didn't, at least at that time. And Dave Stewart describes this well when he said that the system is burdened by market forces, public sector administrative bureaucracy and under-resourcing, inconsistent leadership and a lack of comprehensive strategic thinking and imagination allied on an almost complete absence of usable data. This was highlighted in paragraph 84 of the report, which suggests that drug companies and cancer voluntary sector organisations state that the Scottish Medicines Consortium, the processes are too long and deny the patient access to drugs for longer than they should be the case. This is again conveyed where the report talks about how the processes of the SMC restrict access to new treatment by patients. Given this, the committee therefore unanimously questioned whether market forces should dictate procurement of drugs. Throughout this inquiry, the committee also found the lack of data collection and analysis on outcomes achieved via the prescribing of that was a concern. The impact on individual patients of taking medicines is not being examined at the time of the inquiry, and it wasn't routinely sought. We did hear that pharmacists are working directly in with GPs and in general practice sites, which I welcome, and they are engaging with patients on medication review and addressing issues of polypharmacy. And again, that was highlighted by Alec Cole-Hamilton. It would be encouraging to hear that patients in primary care are receiving follow-up care to ensure the medicines prescribed were effective and to ensure that they are used appropriately. Lindsay McClure of the NHS National Services Scotland said better IT systems and data were required to collect outcomes data. The Association of British Pharmaceutical Industry and the Medicines and Healthcare Products Regulatory Agency, that's the MHRA, they spoke of the need for data on patients who would benefit from innovations in gene therapy and on medicine licensing. Presiding officer, the inquiry found that the lack of care taken to understand people's experience of taking medicines was impacted the system at every stage. The committee are clear that gathering, analysing and sharing this information in a comprehensive, systematic way across Scotland would be the single most beneficial action to result from this inquiry. We agree that this needs to be prioritised as a matter of urgency. And while it is encouraging that the Chief Pharmaceutical Officer stated that the Scottish Government is considering how the voluntary pricing and access scheme could contribute to improving pricing, or to contribute to innovative pricing, but again raised problems with data collection and with data on patients' experiences. This is again emphasised by Community Pharmacy Scotland Director of Operations, who noted conversations are taking place with patients, but the outcomes are not being recorded. Mr Barclay suggests that this could be contractualised. One of the aspects of our inquiry, which was heard in evidence earlier this year in March, was that those that the committee members consider should have the responsibility for solving problems and developing innovative solutions. They were often the people who recounted and identified the issues for us. But these folks didn't propose accompanying ideas or impetus for change. The statements we heard of the need to do something without accompanying detail on how it would be achieved are essentially not effective in driving forward innovation and change, particularly in reference to data and evidence collection. For example, the Right Medicines Pharmacy states the process for licensing medicines could be shortened, but does not state how to achieve this or what the role of the Scottish Government would be in doing so. And the Area Drugs and Therapeutics Committee and Director of Pharmacy state they do not have the power over drugs in their formulary, but fail to say who does and how could this be improved or changed. Indeed, throughout the inquiry, little detail was offered as to how change might actually be brought about, let alone at a pace proportionate to the prize to be gained. Presiding Officer, in closing, the committee urged the Scottish Government to consider the IT and data requirements of the NHS across the country in a strategic way and design systems with long-term utility as a matter of urgency. The committee recognised this as a large undertaking, especially now when we are still in the midst of a pandemic. But similarly, we cannot keep concluding in reports that savings and efficiencies and, above all, better patient care are possible with modern IT capable of data gathering, analysing and sharing without expecting urgent action in this area. The report clearly shows that better data collection along with improved IT systems will both deliver improved outcomes for patients and improved access and use of drugs and medicines in Scotland. Thank you, Presiding Officer.
That concludes the debate on the supply and demand of medicines. It's now time to move on to the next item of business. Very shortly.